Alright everyone, in this video I want to just give you a quick update on what happened at Dr. Nawaz's office yesterday when I saw him at the Gelb Center. Of course, if you saw yesterday's video, you know that the MSE was removed, but some stuff was also added. Okay, so I want to just show you what the new hardware looks like and explain to you what the orthodontic theory is behind what we're now doing with the new elastic setup in my mouth. First, let me just show you what we're looking at so that you can have a visual of the situation. All right. So first, the maxilla with the MSE out. Okay, hope you got a good view of that. And now let me show you the new buttons and elastics on the left and on the right side. So we have an elastic here going from the inside of the left to the outside of the left upper. Okay? And a similar thing going here from the outside to the inside. And here's a view of the whole mouth. All right, let me explain to you what this is all about. So, little background. Orthodontics is not all sexy, fun and games, expansion, splitting sutures, MSE, jaw surgery. No, a lot of orthodontics is boots on the ground, mechanics of moving teeth. And what we're trying to do is just simply to correct my occlusion and to make my teeth look half decent, which is really what all orthodontists do. Orthodontists move teeth. Okay, orthodontists move teeth. They really are not traditionally in the business of moving bone, okay, with these expansion type appliances like the MSE. Really what orthodontists are trained for is this phase of the treatment, which is now that the house has been built, the bone has been widened and established as a large, broad foundation in the expanded maxilla. The teeth moving part is where all orthodontists excel, okay? It's just that the problem is most orthodontists move teeth to the neglect of the underlying bone structure. So we've established the bone structure, now it's time to move the teeth. It's time to establish occlusion and to make the smile look good. Now the big problem with my occlusion, the big problem with my smile, is that I have a crossbite on the left side, which means that the upper left teeth are outside of the lower left teeth. They're too wide for the lower left teeth. So the occlusion on my left side is poor. It's not comfortable. I'm not able to chew well on that side. And so we're trying to get the occlusion on the left side to be better for now. Of course, there's going to be much more resolving of the upper front teeth that are very wonky later, but for now, while my mouth heals from the tunnel graft that I did a few weeks ago, we're trying to just establish a better occlusion on the left side. How are we doing this? Well, we had been doing this by using the MSE as an anchor to torque the upper left teeth in toward the MSE using elastics. Now remember, the whole reason that this crossbite got so bad in the first place is because I had, to some degree, asymmetric expansion with the MSE. It expanded my upper left side more than it expanded my upper right side. And before MSE, I had already had more expansion on my left than on my right, so the MSE exacerbated an existing crossbite. And so we've been trying to correct that by torquing those upper left teeth in toward the tongue. It's called lingual torquing. Well, we're continuing the lingual torquing with this new crisscross elastic setup. Instead of using the MSE, we're using the lower teeth as an anchor to lingually torque those upper left teeth, because using the lower teeth in this kind of joint crisscross method is going to help bring the upper and lower teeth together. When we were torquing up to the MSE, anchoring onto the MSE, it wasn't doing anything to help bring the upper and lower left teeth together. But with this crisscross method, it more directly brings them together in addition to torquing the upper left teeth. Simultaneously, we have a crisscross on the right side, which is just an additional force that's going to help swing my lower jaw over just a hair to help to help correct the existing malocclusion and to help correct the jaw position. So once we do a couple months of this, I should be healed from my tunnel graft. Once I heal from my tunnel graft, we will have more leeway to start moving the upper front teeth very slowly, very gently, using Invisalign to help finalize my bite now and my smile. Now, Dr. Nuaz mentioned some SFOT for me, and specifically what he's thinking, and this is just a thought for now, but he's thinking he doesn't want to do implants for my upper aga gaps. He's thinking that what he wants to do is to mesialize the back teeth, which is to bring the back teeth forward to close those gaps. Why does he want to do this? Because he doesn't want me to have 2 extra teeth on the top as compared to the bottom. If we plug those aga gaps with implants, I'm going to have 2 more teeth on the top than I have on the bottom, and my second molars on the top are going to be useless because there's going to be nothing underneath them. So what Dr. Nuaz is thinking that he wants to do is to drag the back teeth forward using SFOT, which will lower the resistance of those teeth to the forward movement through the corticotomies, and then Invisalign. So he'll mesialize the back teeth, which is to say he'll move the upper back teeth forward using Invisalign and SFOT. At the same time, we'll bring those upper front teeth together, reshape the arch a little bit slowly because those teeth are very damaged and very sensitive. And probably within a year, my case should be wrapping up. All right, everyone. Hope you enjoyed that update on my orthodontic situation, and I will catch y'all on the flip side. All right, be easy. Peace.